It's a great pleasure to be here preparing for the 2024 Annual Congress. It's been an absolute delight to come to Bali and mix with my Indonesian colleagues and friends. And I would like to invite you all to come to Bali and enjoy the wonderful hospitality of the Indonesian Neurological Association. We look forward to seeing you here in September of this year.
It's a great pleasure to join the Arab Association of Urology with the Asian Neurological Association together in Bali. It will be a beginning of further collaboration in the future. I invite everyone to join us in Bali 2024 September. Thank you.
I would like to invite you to come to Bali September 2024 and enjoying the beauty of Bali and also the academic atmosphere in UAA 2024 Conference Bali. Come to Bali. See you in Bali.
I welcome you, all of you, to Bali meeting year 2024 this year. This is really an exotic place to welcome all of you here. So I'm waiting here. Please come and join us.
Join us at UAA 2024 in this exclusive location, where world-class facilities meet tropical paradise. Experience the perfect balance of scientific excellence and relaxation. We invite you to be part of this remarkable event. The Bali Nusa Dua Convention Center showcases Bali's prominence as a preferred destination for international events. Situated in the exclusive Nusa Dua complex, it is surrounded by renowned international hotels, providing convenience and comfort to our attendees.
But UAA 2024 is not just about the scientific programs. We have also put great emphasis on crafting a spectacular social programs. Our aim is to make this conference to be one of the most memorable events in the history of UAE.
I urge all prospective participants to visit the conference website to learn more about the program, secure your spot, and submit your valuable scientific contributions. Together, let us make UAE 2024 a resounding success, a platform for knowledge exchange and a catalyst for advancing the field of urology. We eagerly await your presence in Bali, where science, natural wonders, and cultural delight harmoniously intertwine. Join us for UAE 2024 and be part of this extraordinary journey.
Feel a cozy atmosphere and enjoy the beautiful sunset of Bali. Cheers!
Sawadikap, Indi di Tuan Rapunsu Bali.
Konying, Tachelai Tau, Palidau.
Namaste. Abshabilu, Gosa Bali, Nishwagat Hei.
Annyeonghaseyo, Bali Usin Gyosal, Annyeong Samida.
Ohayo minasang, Bari Yokoso minasang.
2024 Bali. Innovation, transformation, confirmation.
Pa. Maganda lang mag
Hi, Dr. Sam. Can you hear me?
Yeah, I can hear you.
Yeah, okay. So we are now live. And please, probably you can give one or two short introduction about our events. And then we can start the event directly afterwards. Thank you, Dr. Sam.
Thank you, Deandra. So good afternoon, everyone, and welcome to Road to AURC 2024. So to all the participants, to all the presenters, and to all the co-residents who are watching us, this is a new program of the AURC wherein the participants will be presenting cases as sort of a competition to be able to be the one chosen as the final presenter at the AURC 2024 in Bali, Indonesia. This was brought about by the local organization through Deandra, Wayan, and President Poncho here when we discussed the program for AURC 2024. So we thought that this would be a good exercise for everyone to practice your presentation skills, as well as for us also to be able to select the best case presentation for AURC. So for today, to all the presenters, good luck. And I hope that your cases, though the only one will be presented, will really be highlighted and will give a good idea on the cases that you get from your own countries. So to all the presenters, good luck. And to all those who are watching, I hope you would learn a lot from these presentations. Thank you.
Thank you, Dr. Sam, for the introduction to our session today. And then the next opening would be given by Dr. Wayan as the local coordinator for AURC 2024 in Bali. Please, Dr. Wayan.
Okay, thank you, Dr. Diana. Good afternoon, everyone. I'm Yudiana as a co-coordinator and local committee for the AURC program in UAE Congress 2022. I would like to thank you very much, first, to our panelists for your willingness and your presence in this pre-event session at the Sunday. Actually, most of countries in Asia, the Sunday is the holiday. Second, to all of our presenters or nominees, we are really appreciate your support and proud of you, starting or beginning from research and collect your cases, make the report your cases like the abstract and submitted it with the assessment from our panelists until selected as pre-event participant. And third, to all of the audience who made time for this event as this holiday. We hope this event can be an opportunity to get to know or friendship each other, and then sharing the knowledge and experience during the study or during the fellowship, of course, for the clinical practice in the future. Finally, happy the scientific competition. This is not about the winning or losing, but what you put in and how brave you are. So these are the international event. Okay, one more. Thank you very much.
Thank you, Dr. Wayan. With that, probably we can start with the pre-event session for the first topic. The first topic would be moderated by Dr. Ayodhya. So I give the floor and the time to Dr. Ayodhya, please.
Good afternoon. Thank you very much, Dr. Deandra and the committee for this opportunity to join this first webinar, The Road to AURC. And here we have three presenters today for the first topic of challenges in pediatric urology, especially covering proximal hypospadias. We have three distinguished panelists already here today joining us. I am delighted to introduce my teacher, my senior, Professor Gede Wirya Kusuma Duarsa from the Sanglah General, Professor Murah General Hospital in Denpasar. He is also a professor at the Faculty of Medicine, University of Udayana.
Thank you, Dr.
Our second panelist, thank you, Professor Gede, is Dr. Maria Pamela Pahati from the Philippines Children Medical Center, the East Avenue Medical Center, as well as the UERM University of the Philippines. I would like to welcome Dr. Pamela. Thank you for joining on such short notice. So we have Yes, thank you. We have three presenters today. The first one will be from the Philippines, Dr. John Alexis Montemayor. He will be presenting a case of pinoscrotal hypospadias. Dr. John, are you with us? I'm sorry, I cannot see the.
So sorry, Dr. Ayodhya. I think Dr. John has an operation currently, so he asked to be shifted to the last number. So probably we can start with the second presenter first.
Yes, so thank you, Dr. Deandra. So I see here that we have Dr. Mugialan Pushpanathan. My apologies if I pronounce it incorrectly. Dr. Mugialan Pushpanathan from the Malaysian Urological Association as a representative of Malaysia. He will present on staged repair of pinoscrotal hypospadias.
All right. Thank you, Prof. You have pronounced my name absolutely correctly. No worries about that. Just let me open my slides here. Right. All right. First of all, I would like to thank the panelists for choosing my case for presentation. I would like to thank the distinguished professors who have attended this session today for this session. So I will be presenting a case of stage repair of pinoscrotal hypospadias. I'm Dr. Mugilan Pushpanathan, Year 4 Urology resident from Department of Urology, Hospital Sultan Abdul Aziz Shah of University Putra, Malaysia, Kuala Lumpur. It's a university hospital, but I'm currently doing my final year attachment at Institute of Urology and Nephrology at Kuala Lumpur Hospital. So this patient was treated under the care of Institute of Urology and Nephrology at Hospital of Kuala Lumpur. Yeah. So this patient is a 14-year-old boy with a severe pinoscrotal hypospadias. Initially, he was referred to the hospital at 3 months of age for pinoscrotal hypospadias. And at that point, he did not have any other congenital abnormalities and antenatal history of unremarkable. Boy was born term with normal birth weight. So from documentation, the physical examination shows there's a severe CODI with dorsal hooded skin, urethral meatal opening at pinoscrotal junction with a bifid scrotum and pinoscrotal transposition. Bilateral testes were distended and normal in size. So we have performed investigation ultrasound kidney ureter bladder to rule out any upper tract abnormalities. It was normal. So at initial treatment plan was he underwent a first stage Bayes flap repair at 7 years of age. The surgery was delayed due to his small failures. So and during the first stage repair, the chordy correction was done, and it required a ureteral plate excision and Bayes flap reconstruction of using a preputial skin was done. And following which, the second stage, which was recently done about 3 months ago, this point, the boy is already 14 years. The period of delay between the first and second stage was 7 years. The reason being, one is for the failures to grow, because the failures was still small, and another one of the cause of delay was because the COVID, which apparently delayed the surgery timing of surgery itself. So during the second stage repair, ureteroplasty with preputial skin tubularized over a 10 French ureteral catheter, and the anastomosis was closed by double layer closure using a dartos tissue interpositioning. So this is images prior to the second stage hypospadias repair. So you can see from the first image, this is from the Bayes skin at the ureteral plate. It have taken up very well, nicely, and there's no skin or hair over the ureteral plate area. So the second image is following the second stage repair. We have managed to close the bifid scrotum as well, reconstructed it very well. And during our review about 6 weeks post-surgery, the wound was well healed. He had a very good urinary flow by Qmax of about 12 mils per second. He had a normal straight erection. Both patient and the child's mother, boy's mother, was very happy with the outcome of the surgery. So in conclusion, penoscrotal hypospadias is often associated with a severe CODI, which necessitates a 2-stage repair. Ideally, it should be done earlier. Most of the times, it's done within 2 years of age. At least the first stage will be done. But in this case, we choose to delay it for the small failures so that it will give more tissue for reconstruction. So that's the end of my presentation. Thank you.
Thank you very much, Dr. Mugialan, for this interesting case. And I think this is a case with features that we frequently see in daily practice. For the first panelist, can I kindly request Professor Duarsa for his comments on this case?
Thank you, Dr. Ayodhya Subadi. Is there any limitation time or not? Because this is a very, very interesting cases that we will face almost every day in, as a pediatric urologist, and then this is a very good one. So I have some question, some discussion with you, because if you see our publication from Indonesia, from the Society of Pediatric Urologists in Indonesia, we also do the surgery not in the first or second years, most of us, but we do the surgery at around 3 to 4 years old, due to our Asian penile size is not good as you mentioned before. So what is the average time in your hospital, the hypospadia repair? This is the first one. And the second, could I ask you that what do you think about the testosterone treatment for the patient whose penis is not good? When will you give the when will you apply the testosterone in your hospital, in your experience, in your consultant experience? Again, you present the case is very good, but if you like to see the last picture after the second stage surgery, I said that is there any penoscrotal transposition, a little penoscrotal transposition, and then will we repair that one or not?
Oh,
yeah. Okay. And then the last one from me, sorry. No, this is not an examination. This is a question
Yes.
because I would like to discuss with you also. Me and my student also publish some paper about the QMAX after hypospadia repair. Hypospadia repair. So what about your data in your, if you don't have that data now, you may present it later on in the offline meeting. What is the average QMAX of the patient hypospadia after proximal hypospadia repair? Thank you.
Okay, Prof. Dwasa. So can I answer first, or should I collect the questions from so I can straight answer, right?
Yes, answer, please. Thank you.
Okay, from my experience on testosterone, I missed the first question, Prof. Dwasa, if I remember the second question. So the second question is about testosterone usage for prior to the repair, hypospadias repair. So in my limited experience under the pediatric urology consultant here, we are not routinely using, I think not commonly being practiced to use testosterone in our community here in this moment of time. But we are aware that some surgeons do practice using with a moderate level of evidence of usage of testosterone in improving the outcome of hypospadias repair. But in our practice, it's not there. Yes, there is some level of penoscrotal transposition there. Okay, during the surgery, I was there during the second stage repair. The closure, we do not. This is as much that our practice we leave it. We don't close it because we think the skin may remodel as the boy grows further. This is what I received from my, yeah. Okay.
I think the first question was about timing of what age is commonly the children that undergo hypospadias repair. At what age do they commonly present? Does this case perhaps is slightly later than usual?
Yes, for this case is particularly it's later, but commonly here it's done earlier. First stage repair usually less than 3 years old or before the child goes to school. We have done the repair already. But in this particular case, there was a delay. The delay was particularly because the child was persistently during follow-up. The penile growth was not adequate for the surgeon who's going to perform the surgery. Prefer it to be of a larger gut. So that's why she delayed the surgery.
Yes, thank you. Professor Gede Wiryaduarsa, he mentioned about maximum flow. Yes, is that?
Yes.
Yeah.
What about your QMAX in Malaysia? Sorry.
The QMAX we do by we are accepting anything more than 12 mils per second as an acceptable QMAX. But we on collection of data, probably we can collect some data on that and share with all of you during the coming meeting. Possible?
Yes. All right. Very possible, but I found very difficult. I found many difficulties to do the QMAX in children because it's hard to say the children how to hold the pee and how to start the pee, and some of them are crying, so a little bit difficult. But yes, we have data, and the average QMAX of our patient for 3-4 years old is around 9 to 10 milliliter per second. Okay, very good one. Yeah, I'd love to see your data because every single type of hypospadia repair will give a different result for the QMAX.
Okay, all right. Thank you, Prof.
Very good.
Professor Duarsa, I would like to ask Dr. Pamela Pahati for your comments and questions.
Hello.
Hi, Prof. Maria.
Kayaknya ketendang deh.
She's rejoining. I'm sorry. Yes. So if I may, while we wait for her to rejoin, is there a possibility to have more more pictures of before or during the surgeries of this case? Because that would be interesting, as this has been a very extensively operated on patient. Do you have more data on this patient? I see that Pamela has joined.
Hi.
Hi.
Hi, good afternoon. Good presentation. I think that hypospadias really is a visual type of pathological disease in children. So what I would suggest is in your physical examination, you have to already put the picture of your the penis of the patient. Yeah. So that and you have to like point as to where is the urethral meatus, because I think you are dealing with residents here, for some of which are not yet adept to seeing hypospadias patients. So my suggestion first in your physical examination is to put your picture, and then what you describe in your physical examination, you have to point out to the picture which you are presenting. So the hooded prepuce, so those are very important because those are landmarks of, those are the physical examination that you see in your hypospadias. So important to highlight, just to give them already, a picture of your patient. I was wondering, because you told in your presentation, you said the patient has a small phallus.
Yes.
Do you have phallus, meaning how do you say that the patient has small phallus? So my first question, if you have any penile length, what do you mean by small phallus? Is it regarding with the penile length, with the glans measurement?
It's more of a glance measurement. That's Pamela.
Okay. So I think important also to note the glance measurement in your physical examination. And then so why did you opt for a Bayer's flap? Or for this patient?
Okay. Any other question, or should
And
I?
then what is the significance of a bilateral descended testes in patients with hypospadia? How will it change your management?
Okay.
Okay.
All right. Can I answer already?
Yes, please.
So I take into consideration, I should have maybe explained more about the picture in the initial. I apologize at this point that I do not have the prior images because of the long duration of time, where it was almost for 10 years, 14 years, right? So the initial examination at this point, the images are not available for me how prior to the first stage repair. What I showed was the reason one, which was prior to the second stage repair, where the meatus is still at the pinoscrotal junction. It's just although it looks like very nice skin over the trachea, over the urethral plate area after the division of the urethral plate, it's just it's prior to tubularization of that. On your second question on why assessment of the examination findings, yes, I will add on more on the examination finding, because this again, because of the long duration period, there's some notes missing. That's why I couldn't get it enough on that part. All for some of this information are based on my consultant who are handling this child, from her personal knowledge about this patient. So I get that also from that. In terms of phallus size, okay. The reason I ask, is it length or glance? She is more considered about the gut, which is say glance measurement. So she want adequate glance measurement for the tissue tubularization, and on her point of view, she thinks it will improve the flow and also stricture. She's well aware also about complications like erythrocutaneous fistula which may arise. On your last question on will it change my management if the child was having bilateral undescended testis? Is that right, Dr. Prof. Mira? So yes, I'll be more concerned if this child is having other problems like ambiguous genitalia or not. So I will investigate, put my line of investigation on that in the initial phase of attending to the child. And also my surgery maybe will be definitely early because the undescended surgery, orchidopexy should be done within 2 months, 2 years of age. So that will definitely change the surgical management. Probably maybe do the orchidopexy first and then do surgery for hypospadias.
Unfortunately, this is the end of time for this this first session, question and answer. Thank you for presenting an interesting case and also answering all the questions from the panels. May I close this first session and we can move to the next presenter? Thank you very much, Dr. Mugialan.
Thank you. Thanks a lot, Prof. Parisit. Yeah, thank you.
Yes, I would like to introduce Dr. Chananya Dausuk. I'm sorry, this is, I probably have mispronounced it, but Dr. Chananya Dausuk, she will present a case on behalf of the Thailand Urological Association on cripple hypospadias. The time is yours.
Good afternoon, all professors, ladies and gentlemen here. I am Chananya Dausuk, fourth-year urology resident from Sirirat Hospital, Thailand. It's one of the oldest and has the highest volume of cases, especially in urology department. I'm very much honored to have a chance to present this interesting case that I pre-selected. And the case I'd like to present today is a cripple hypospadias, which is defined as a boy or a man who has undergone repeated unsuccessful repairs, remaining the significant defect with poor function outcome. The case is a Thai male, 25 years old. He has no underlying disease. His birthplace was at Pathalung, Thailand, which is in the southern part of Thailand. He's been having and dealing with this congenital abnormality ever since. His chief complaint was that he primarily void via penile shaft for 8 months. For patient history, he was diagnosed as penoscrotal hypospadias. He underwent the first hypospadias repair at the age of 4 months old. On postoperative, he developed erythrocutaneous fistula, and he had a history of UTI and urinary retention several times. And he underwent the multiple repair about 4 times, 2 times at the age of 9 years old, and 1 at the age of 10 years old. And the last repair was in March 2023, the age of 24 years old. Before this visit, he had recurrent febrile UTI 3 times a year, especially after sexual intercourse, with 80% voided urine from fistula at the proximal penile shaft. He has normal erection and able to have sexual activity without any problems. On physical examination, there is no penile curvature. The defects are primarily on ventral side. So as the blue arrow, there is subcoronal hypospadias opening with glans dehiscens and about 3 centimeter inclusion cyst. His testes were palpable both in the scrotum. And there are 2 fistular, which is in the penoscrotal junction and where 80% of the voided urine came out and the majority of the semen as well. So after the patient first visit, we schedule him for exam under anesthesia with cystoscopy. The findings show 3 centimeter inclusion cyst at the distal penile part, 1 centimeter below the neomeatus, with 1 millimeter urethral-cutaneous fistula tract, 2 urethral-cutaneous fistula at the pinosquado junction, size 1 centimeter. Neourethra can be applied knee-laden tube, 12 French easily. On cystoscopy finding, there is normal prostatic urethra, and there is few hair in neourethra at bulbal membranous junction. There is no mass in bladder, no vesical calculi, no trabeculation, and normal both ureteric orifice. So he was diagnosed as pinosquado hypospadias, status post-repair with urethral-cutaneous fistula, or as we call cripple hypospadias. So on pre-surgical planning, we discussed with the patient on expected surgical outcome, including the functional outcome, which is to completely close the fistula and be able to have a distal voiding, and about the cosmetic outcome, whether he would prefer his neomeatus to be at the most distal on meatus as possible, or if he's satisfied with the subcoronal opening, which he also has a cosmetic concern. So we schedule the patient, we perform the primary repair fistula with excision inclusion cyst with harvest buccal graft with single stage buccal graft onlay dorsal meatoplasty. We did it on March this year. Total operative time was 3 hours and 5 minutes. The estimated blood loss was 20 milliliter. The patient was sedated under anesthesia with the nasal intubation in order to prepare patient for buccal graft harvest. We started the operative field by suture hang both squattal skin using a traumatic nylon 40. We worked the way up from dissecting both fistular and found that the quality of the local tissue was still excellent. So we did not use the buccal graft in this site. Simply, we just dissected away and closed fistula with monocryl 60, as in this diagram, the drawn diagram. And then the squattal skin flap was dissected and mobilized to cover the fistula. Then the plastic surgeon team came to harvest the buccal graft on the left side. The concept of harvesting the graft was to avoid the parotid gland duct opening and avoid the oral commissure. The mucosa suture was sutured with Vicryl 40. And then we performed the inclusion cyst excision at the distal penile shaft. And then we worked on meatoplasty part, which the skin was incised, and the dartos fascia, bulbospongiosus muscle, and buck fascia was just dissected layer by layer. And we insert the Foley catheter 16 French. Then the buccal graft was suture hang with the meatus using the Vicryl 60. And then we performed the uteroplasty. On the post-operative care, we opened the dressing on post-operative day 2, and he was able to have a solid diet on post-operative day 3 due to the buccal graft harvested site. And the Foley catheter was removed on post-operative day 15. So this on the right side picture show the about 1 or 2 weeks after the operation. On the follow-up, at the post-operative 1 month, there is a small fistula at the repair site with 90% of urine via the distal opening. And this is we advise the patient to record his voiding by himself when he's voiding so that we can evaluate how his functional outcome came out. So this is a picture on post-operative 4 months with still minimal dribbling on voiding at the fistula site. So we dilated his urethra using T-man or Coude tip catheter 14 to 16 French to keep the tract at the distal wider. So the next follow-up will be in next 6 months. For conclusion, I learned that a well-planned surgical approach is essential, especially in complicated and reoperation case. And we can use extra genital skin harvest it is another option in the setting of salvage hypospadias repair. Thank you for everyone's attention. Is there any other questions?
Yes, thank you very much for presenting an interesting case. And I see that Professor Duarsa is very interested in the case presented, and he has already unmuted himself. Duarsa.
Okay. Thank you, Dr. Yodi. Chanaya, very, very good presentation again. And I'm very proud of you and your friends before. Yeah, this is a very challenging cases, especially when we do the several hypospadia repair. And after all, one thing that we have to remember that the first chance of arthroplasty repair is the best chance. So try to do the first operation with the best result. And then my teacher, Dr. Tarmono, Professor Tarmono, and Professor Ari Rojani always told me that first of all, free from corde. Let the penile straight first, and then the rest will be much easier. Even if there is a fistula, then we will repair. The repair will be much easier. So make the penis, the penile straight first. Okay. Then I'm also agree with your team and your senior colleagues, and also the patient decision for distal hypospadia is there is a very big debate on that one. Should we do the repair or not? In many cases, in such cases like now, like the one that you present, I'm very, very agree with the decision. Do not touch the distal part of the meatus. The meatus and the subcoronal is sufficient. So we have to go back to the goal of the hypospadia repair. First of all, is the straight one, machinery in standing position, and let the flow go to the front side, then able to do the sexual activity later on. And the cosmetic is the last goal. And the Campbell's book also said the distal hypospadia will only repair for the cosmetic goal. So in a very bad crippled hypospadia like that one, so let the meatus at the distal at the coronal is one of the wise decision. I only have one question for you. What do you mean by the onlay graft? What is the difference between onlay and inlay graft in your cases? Because in I don't know if I did that one, then I will open that one again in the distal part and open in the midline, and I put the graft inside, inlay graft to augment the urethra, and I will close that one. So, or you do it from the side, we call it the onlay one. So, what did your colleagues, your senior colleagues do? Is that the onlay or inlay? Thank you.
My professor did the onlay graft because I'm not really sure about the reason if we could perform it in the other way, like the inlay graft, but the defect is mainly on the ventral side. So we just approach at the ventral side. We work the way up along from the proximal to the distal, and at the distal part where there is the defect. So we just repair it from where there is a problem. So we didn't go into the urethra and to do the inlay. So I think onlay would be the solution for this. I'm not sure if we can do the inlay though.
Dr. Ayodhya is also, Professor Ayodhya is also the reconstructive urology surgeon. Then he will explain a little bit on. But as far as I know, if the bed for the graft is okay, then putting the graft behind is one of the question, one of the good choice. And for the proximal bulbar hypospadia, proximal bulbar stricture or something, we can put the graft at the frontal side and put the muscle of the bulbar muscle to fit the graft. But if in the ventral side there is no blood vessel, there is no muscle, then put at the behind of the urethra is one of the choice in my hand. But I don't know because your professor maybe the one then, but the most important thing that I see is a very good one. Very good one. Okay.
Yes, thank you, Professor Duarsa. So it would be an interesting discussion later on for the approach to the urethra and the onlay and inlay and placement of the graft. Dr. Pamela Pahati, please, your comments and questions.
Very good presentation. I was able to visualize what you were trying to say to us, the audience. I totally agree with Dr. Duarsa. The three primary reasons why you correct your hypospadias. So a lot of the patients will have ureterocutaneous fistula primarily because of recurrent chordae or curvature in patients with hypospadias. Also important to note the use of a non-hair bearing part if you're trying to repair or if you're trying to do your neo urethra or your new urethra, because I noticed this patient had a hair in the bulbomembranous. So first question is, in the long term, what might happen in patients with when you use hair bearing as your new urethra? So when you see hair in the new urethra, what are the long-term implications and what are the possible management in terms of hair in the new urethra? And then yes, crippled hypospadias is very difficult because a lot of the tissues has already been mobilized. So can you comment on the use of hyperbaric oxygen in patients with hypospadias? And last comment is your inclusion cyst. It's a very interesting case because inclusion cysts is even in hypospadias are very rare. And I agree with the management of, apart from corrective hypospadias complication, you have to excise completely your inclusion cyst. So I totally agree with the management. So great presentation. Thank you.
Thank you, Professor. To answer your question, what will happen if there is the hair in neourethra? First of all, it goes back to the OPD setting. Whenever that I follow up the patient, when those patients will perform the hypospadias repair since they were young, I have to check out the genitalia, whether there is the pubic hair already or not, because I always have to concern about this. If there is the hair, then I would later maybe send for a uroflow to see the Qmax, or maybe just asking his symptoms if there is any obstructive symptoms. If there is, it could cause bothersome symptoms. So the definite diagnosis or the investigation would be cystoscope to confirm if there is the hair in neourethra. And then we will just do, in my practice, we just do the hair plucking using the foreign body forceps and just repeatedly goes in and out and just pulling hair. And it could stay, the outcome after hair pulling would be about, I have seen about between 6 months to a year or two, but then the patient has to repeatedly come back for this kind of operation. Is there any other questions that I missed?
Thank you, Doctor. Thank you. Yes, hair plucking you can do. Also, some would do laser to remove the hair for long term removal of the hair, because when you pluck in 6 months it will grow. Thank you. Great presentation. Great presentation.
Just do not let the hair in the urethra.
Yes, and a lot of these patients that have stones.
Yeah, unless you put bomb inside there, then one day the time bomb will blow.
Yes. Thank you.
Did I miss the reply about the hyperbaric oxygen? Do you have experience in Thailand, in Philippines, or in Indonesia, in Bali?
I have never seen the practice in, like, after doing the urethroplasty, not only about the hypospadias repair, right? I haven't had experience yet.
I think yes. I think now they're just looking into the use of hyperbaric in terms of increasing the vascularity, because a lot of this patient already has been mobilized, and even if you um even if you've corrected it properly, sometimes the vascularity is not as good as the first surgery. So you can look into that also, so as to improve the cases in terms of the operation in people hypospadia.
Yeah, very good suggestion that I would like to read more. Yes, there are some many literature said that the hyperbaric will increase the vascularization, but I have no experience on that one. Then it's also not the algorithm in our hospital. So, but it's very good one. We do for the diabetic food, etc. Do the hyperbaric. Good option. I will think about that. Thank you.
Thank you very much. I think this was a very interesting case with aspects that we need to explore further. I thank you, Dr. Chanaya Dausuk, and I would like to invite our final speaker for this session, Dr. John Montemayor, John Alexis Montemayor, from representing the Philippines Urological Association. Dr. John Alexis Montemayor, time is yours.
Thank you. A pleasant day to everyone. I am Dr. John Alexis Montemayor from the Philippine General Hospital. On behalf of the Philippine Urological Association and the Philippine General Hospital, I present to you a case of penoscrotal hypospadias with CORD in an 11-year-old male. So, hypospadias remains a challenging task for urologists. One of the major concerns is the high rate of post-operative complications. These complications significantly impact patient outcomes and recovery. One of the areas of studies in hypospadias is the recommended age for surgical correction, since there are reports that increasing surgical age can lead to poor surgical outcomes. Hence, my presentation would be a delayed surgery due to socioeconomic status. So, an 11-year-old male was brought to our outpatient clinic for abnormal location of urethral meatus and penile curvature. Our patient is a product of normal pregnancy, and there is no history of prenatal anti-androgen exposure. Since birth, he has been doing well. There has been no documented urinary tract infections. He and his parents have observed good urinary flow in the sitting position. His erections were associated with non-painful ventral curvature, and family history is significant for an older sibling with a similar condition. So allegedly, staged surgical correction was advised for this patient at 6 months of age in another institution, but was delayed for 11 years because of financial constraints. So here on clinical examination, the urethral meatus was located at the penoscrotal junction, accompanied by a ventral penile curvature and incompletely formed foreskin. Bilateral testes were palpated at their respective hemoscrotum. Glans width was more than 14 millimeters, and he is Tanner stage 2. There is existing CORD even on the flaccid state. So there's no lumbosacral deformities were demonstrated, and no suspicious abdominal mass were palpated. So for this case, with an isolated penoscrotal hypospadias and CORD, we deemed it not necessary to order for any additional lab exams or imaging tests. No workup for disorders of sexual differentiation was also done. So based on the history and PE, the working impression for our case is a penoscrotal hypospadias with CORD. The initial surgical procedure involved the correction of CORD and utilization of Bayer's flap. The degloving of the penile shaft and excision of these plastic tissues were enough to achieve functionally straight phallus. Dorsal plication and ventral corporotomy were not done. To address the redundant dorsal preputial skin, a longitudinal division was made, followed by its ventral transposition utilizing its vascular pedicle. A comprehensive penile dressing and Foley catheter French gel were left for 24 hours and he did well post-op and was advised for a second stage operation after 6 months. So here on follow-up after the first operation, the phallus after the first stage hypospadias repair shows a deeply grooved, healthy urethral plate with adequate size and also resolution of the ventral curvature. The second stage repair was done a year later. The operation started with a stay suture placed in the glans penis and lateral folds of the penile skin. Incisions were meticulously planned and marked using a surgical pen, and a long U-shaped incision was made, extending to the urethral meatus at the penoscrotal area. Glansplasty was performed utilizing a standard tierce-du plate technique. A French 12 siliconized catheter was inserted into the urethra, and urethroplasty was conducted in a continuous subcuticular fashion, employing Vickel 5O sutures in 2 layers. Lateral dartos tissues were adequate to serve as a second layer, covering the urethroplasty. So the skin was closed using Vickel 5O sutures, and pressure dressing was applied, followed to the patient followed up after 2 weeks where the Foley catheter was removed. So this patient on follow-up is voiding freely with all suture lengths intact and healing well. So this patient is voiding upright on follow-up and does not complain of lower urinary tract symptoms. And he has no UTIs and straight erections were observed. In our institution, there is no strict schedule for follow-up. Immediately a week post-op, then if younger, when they reach toilet training age, then as needed basis if there would be any problems. And one follow-up is advised before they transition to adult urology care. So here is the appearance of the phallus after 3 years post second stage repair of hypospadias. There is adequate diameter of the neomeatus at the level of the coronal sulcus with overall satisfactory cosmetic appearance. There was no noted urethrocotaneous fistula. So although the exact timing of surgery when treating children with hypospadias is still controversial, it is widely accepted that patients should undergo early surgical repair. The EAU guidelines recommend surgery performed between 6 to 18 months. Delayed surgery is defined as more than 18 months. Hypospadias repair before 18 months can minimize psychological trauma caused by the surgery, such as rapprochement, stranger anxiety, and separation anxiety, enabling better adaptation to social roles. In a study by children without comorbids, including cryptorchidism, prostatic cyst, inguinal hernia, and living in a low economic area are risk factors for delayed surgery. So a study by Garnier noted that boys more than 2 years of age was a significant predictor of complications related to dyssynergia, and boys more than 13 years old were more prone to healing problems. Fortunately, in this case, the surgeries were performed without any morbidities, and the patient has recovered well. Management of proximal hypospadias remain a challenging procedure, and the incidence of post-operative complications are high. So conversations have been around regarding need to repair distal hypospadias, use of operative testosterone, the ideal operative technique, and the use of stents, and ways to manage complications. So basic science researchers have also focused on cell responses and epigenetic mechanisms involved in development or wound healing in hypospadias. The hypospadias literature is vast, but with an encompassing limitation that they lack long-term assessment of outcomes, and the techniques and variables assessed are heterogeneous. All this should be relayed to the patients and parents when we're getting consent and discussing possible complications such as bleeding, poor cosmetic result, or infection, stricture and residual chordae, urethrocotaneous fistula, and diverticulum formation. It should also be underscored that transitioning these patients to adult care is equally important. So follow-up should be centered on their lower urinary tract symptoms and reproductive function. So thank you for this my words.
Thank you very much, Dr. John Alexis Montemayor, for the very comprehensive presentation. So again, I invite our first panelist, Professor Gede Wiryakusuma Dwarsa, to comment and
let Miss Pamela first.
Dr. Pamela Pahati, your comment.
Why, Professor? Okay, thank you. I was just going to agree with what Professor was saying, but on my end, yes, I agree with the management in terms of it is also critical that we assess the ventral curvature, the presence or absence, even on the second stage. So always remember that in patients who will undergo second stage, straight penis is a must before you do your urethroplasty. In terms of technique, yes, a lot of techniques from Snodgrass to Hadidi. So we have so many techniques in terms of the hypospadias. But of course, you do your technique which you are more comfortable doing, where you have the highest success rate. So, in terms of your case, you can do Bayers in terms of near urethra or even preputial graft in terms of doing your near urethra, and both of which have their pros and cons. So my question is, of course, you're dealing with an 11 patient, and we know that a lot of psychosexual issues will happen when hypospadias are treated later in life. So more so with penoscrotal hypospadias, I don't know whether the patient is peeing or urinating standing up or sitting down, how the patient deals with hypospadias moving forward in preschool, going grade school. So did you see consult for an adolescent? Because now we also have adolescent pediatrics.
Yes, ma'am.
So how did you deal with the psychosexual issues of this patient? Was this patient referred to an adolescent pediatric? Before the surgery, was consent also given? So did you get consent also from the patient? Because also for patients greater than 7 years old, apart from the consent of the parents, you also have to get assent. So those are my questions.
Yes, ma'am. So for this patient, we also got consent, and we discussed extensively with the patient the effects of the surgery, as well as transitioning forward his sexual function and erection symbol. For the referral to pediatrics, adolescent pediatrics, I think he is also on board, but more of us already discussing with the patients what to expect with these kinds of surgeries. So we already discussed with him the possible complications that there might be, that he must be aware of. So if he would have, he might have problems with voiding afterwards or erections, that he must follow up, since our follow-up for this patient is usually just a week post-op, then as needed. So he is very aware when he will have to follow up. Then at the age of when he will transition to an adult urologist, so it's usually also us, we also advise him to come back for follow-up, so that he will be aware of what the possible complications and expectations, especially his post-surgery. And it's also very important if he will seek to the surgeon that he did the hypospadias repair, would have to thoroughly endorse to the adult urologist everything, the operative technique, how the hypospadias initially presented, since there's some problems if there would be no coordination from the pediatric urologist and the adult urologist once he transitions to an adult urology. Thank you.
Dr. Pamela?
Thank you. Last question. Do you also do meatal dilatation for patients with hypospadias, for your patients?
For our patients, we don't usually do dilatations unless there's a decrease in there's a problem with voiding. But for this, most of our patients, we first assess for distal obstruction. Sometimes we do RUGM or uroflow, but the urethral dilatation will come after those diagnostics. We don't usually advise post-op urethral dilatation, ma'am.
Okay, thank you very much.
Thank you.
Yes. Okay. If there are no further questions from Dr. Pamela Pahati, Professor Duarsa, you have 5 more minutes.
Okay. Years ago in Indonesia, economical reason is also one of the causes of hypospadia neglected operation. But nowadays, because of our good national insurance health, then every single congenital anomaly will be covered by the national insurance health. So thanks God for that one. Yeah, when we do the adult or adolescent hypospadia repair, when the penile is already bigger than the baby bores or the child size, then we have many difficulties of that one. Not only because of the mechanical, because the enlargement of the penis when they has an erection in the morning. We also have some difficulties from normal flora at the skin because there is a hair already there, and also the collagen and the collagen type of the penile will be changed. Also, the fibrotic and the elasticitas of the ductus tissue will be changed. So, in adolescent or adult hypospadia will be very challenging. It is in my opinion. First of all, you have a very, very good presentation from the beginning to the end, from the starting and until the end. But I have some question also. Okay, a moment. Okay, so what about the buyer's flap? Once you do the buyer's flaps. Also, sorry, another comment. You can see at your picture that the meatus is also not at the tip of the gland, but a little bit below the tip of the gland. Yeah, and it is okay. You can see from the penile size. If we deal with the proximal hypospadia, usually the gland size is not as big as the normal one. In many cases, you can see at your picture also the gland size even a little bit smaller than the shape of the penis. So we don't have to push. We don't have to push the neo-urethra tip of the gland unless you will have the metal stenosis. Then you need the dilatation. So in my experience, we put the gland. We put the meatus not always in the tip of the gland. Yeah, including the width of this, the width of the glands.
Yes.
And also, according to the Pamela question, Professor Pamela question just now, that what about the penile perception score? We also present some one paper of penile perception about that one, because of Indonesia is the Muslim countries and most of the children do the circumcision for religion reasons in the adolescence, so we don't have any difficulties in the mental problem or penile perception score. Everything will be okay. So one question for you is about the buyer flap. According to Professor Pamela, also she said that why don't you use graph? Why did you use the buyer's flap as the first choice? And you have any particular reason why don't you perform the DACEP procedure or Kayanagi procedure? Do you have any experience from your teacher, from your professor? And also, one question from the buyer flap. If we do the buyer flap, if we do the flap, usually we put it in the catheter inside. Then I will bandage the penile for 5 days to let the flap attach to the body of the penis.
Yes, sir.
So your presentation said that you remove all the catheter in the first day. So do you have any opinion on that? Thank you.
For us, usually for the first operation, the catheter was removed after 24 hours. In our institution, since it's just the first stage, it's just for drainage of urine. So they don't practice to prolong the Foley catheterization for the first stage. But on the second stage, when we do the urethroplasty, and that's where we maintain the Foley catheter for at least 2 weeks. For the technique of the buyer's flap, we usually, that's the the technique we're most comfortable with. I think that's why we and it was feasible at that point. So I'm pretty sure that there's more technique, but and we are all most of my consultants here are familiar with many techniques, but for us residents, it's the most usual technique that we do. So I think that's the reason why we did the buyer's block participation.
What about the bed dates for 5 days? Because we know that within the first to the second days to the fourth days, usually there will be a neovascularization from the body of the penis to the flap, so that the flap will be attached to the penile body. Because as far as I know, if we remove that one, then the flap will not attach. What do you think about that one?
Yes, sir. I think that it's important that we still maintain the catheter, but for this patient, I think we tried to remove it early, and luckily we were able to have a good outcome, sir. But,
okay, very good. Yeah, there are many suggestions about the proximal hypospadias. There are many techniques on that one, and I also prefer to Indonesian urologists. 13 of pediatric Indonesian urologists will do 2-stage rhinoplasty for the proximal hypospadia. Only a few of them, few of us that will do the koyanagi or the daket procedure for 1-stage rhinoplasty, because once if we face with the complication, then the second 2-stage rhinoplasty will be corrected much easier than if you do the 1-step only hypospadia repair. So I agree with you, and then also Ms. Pamela said that there is no big difference whether you use the graft or the flap. The result is not significantly different. Thank you, Dr. Yodi. Very good.
Thank you, sir.
Thank you very much. With this ends all presentations and time for the first for all 3 sessions here for the first topic. Again, I thank you all presenters, all panelists, and all of the audience for joining us today. But please do stay for the next topic, which will be introduced by Dr. Diandra. Again, thank you very much for the committee. Have a nice day.
Thank you, Dr. Yodi, for an excellent, and all the presenter and panelists as well for the first session. It's a very interesting, very packed. I feel like it's a testament of our oath to move forward with urology, especially in Asia. So again, this is actually the first time for UAA and also AURC to have an assessment together as a discussion, a case discussion with all the participants throughout Asia, and also the panelists from throughout Asia as well. So for the first topic, I thank everybody. It was a success, and now we move on to the second topic. The second topic there is going to be about complex renal stones and its management. We have 3 panelists, including myself. The first one would be Dr. Chandra Mohan. He's the senior consultant urologist at Priti Urology and Kidney Hospital in Hyderabad, India. He specializes in various subspecialty, including oncology, reconstructive, and also endourology. He is currently the elect secretary of the Association of Southern Urology. For and the second panelist will be Dr. Indra Warman. He's he's subspecialized in endourology and also oncology. He currently practices at Sarjito Hospital, Yogyakarta, Indonesia, and he went through fellowship on laparoscopic, robotic assisted laparoscopy, surgery, laser, and endourology at University of Heidelberg. He's currently the head of urology study program at Faculty of Medicine and Health Science, Universitas Gajah Mada. So we have 3 presentations today, 3 residents. Without further ado, probably we can start. I encourage everybody, all the attendees here, if you have any questions, please put them in the question and answer chat box. And then if there's time, of course, we can discuss them as well. So for the first topic would be from Dr. Ma Sui Fai with the title E-Sears in a post-radical cystectomy and ileal conduit patient with renal stones. Dr. Masui, the time is yours. Is Dr. Masui ready?
Hello, everyone.
Yeah, hi.
Can you hear me?
Yes, yes.
Okay, thank you.
Yes,
so,
I can hear you. Go ahead, please share your screen first.
Okay, I'm going to share my screen.
Yeah.
Okay, wait a second. Okay, good afternoon, everyone. I'm Alphonse Ma from Hong Kong Urological Association. Thank you for inviting me to join this pre-event webinar. It is my pleasure to be here. Today, I would like to share a case of ECIRS in a post-radical cystectomy and ileal conduit patient with renal and ureteric stones. So, Mrs. Pan is a 67 years old lady. She was a non-smoker with good performance status. She has a drug allergy to 2 antibiotics, namely cephalosporin and tazocine. Also, she has a long history of type 2 DM since 2008 and currently on insulin, and as well as some chronic kidney disease and obesity. For her urological history, she has a muscle-invasive sea bladder with open anterior accentuation with ileal conduit done in February 2020. A Wallace type 1 ureteroileal anastomosis was performed. Pathology come back to be PT2 and not disease, and margins are all clear. And pre-op, we had done a PET-CT on this patient. There is no distant metastasis, and at that time, there was no stone bilaterally. Post-operatively, the EGFR was around 30-something. So subsequently, after her cystectomy and ileal conduit, we saw her first on June 2020, which was around 4 months after the cystectomy. At that time, actually, she had no major complaint except occasionally found some debris in the conduit urine. There was no hematuria or loin pain. Physical exam was unremarkable, except an easily reducible incisional hernia over the lower midline wound. However, her blood test revealed deranged renal function with EGFR down to 15 and also metabolic acidosis. UH level come back to be elevated to 0.4 and urine pH was just 5. So in view of her acute renal function deterioration, we had immediately did some basic workup, including breast ultrasound and KUB. Here we can have a look on the KUB, so see if you can spot any abnormalities right. Actually, we can see there's a left upper pole ureteric stones, and there's a faintly seen a chain of proximal ureteric stones. So in the breast ultrasound, we also found there's a left hydroureteronephrosis, and the right side is actually normal. So in view of that, we had ordered an early NCCT for workup and started her on sodium bicarbonate for her metabolic acidosis and also for urine alkalization. So unfortunately, the NCCT was not done until March 2021. The delay was actually due to severe COVID outbreak at that time, resulting in large-scale surface cut down. After the delay, we have repeated her blood test, found the renal function further deteriorate with EGFR down to 9 only. However, her metabolic acidosis has improved and the urine pH was back to 7. So, and also we have done the NCCT. Here we can have a quick look on the NCCT. Here we can find there's left upper post stones with a chain of left ureteric stones. And the appearance is quite matrix-like. And as you can see, our conduit is situated on the right lower quadrant. And also there's here is the conduit. And here you can see there's incisional hernia. So here is the coronal view, which we can appreciate the ureteric stones and renal stones better. Yes, you can see. Oh, sorry. So, and also we have checked the urine for culture, come back to be Klebsiella, also ESBL proteus and Enterococcus species. So the summary, there's a chain of ureteric stones. The length of the stone chain is around 4 centimeters with Hounsfield unit around 200 to 300. And also for the left upper post stones, it is around 2 centimeters with a FH Hounsfield unit of around 500 something with a maximum Hounsfield of 800. So the working diagnosis at that time would be U-raised or screw-face stone with or without left ureteroileal anastomotic stricture, because we cannot see any stone over the right side. So we suspect that can be possibly due to the anastomotic stricture over the left side. So here's come the treatment plan. So here's is all the options we have in dealing with both of the renal and ureteric stones. First, for open or laparoscopic nephrolithotomy, I bet no one would like to do this kind of operation in a patient we already had undergone open surgery with cystectomy and ileocondyl. So this is not a good option. So how about URSL or RIRS? So it's definitely not a choice of option because of the difficult retrograde access after the ileocondyl. So how about ESWL? Also no. It may be a good choice for tiny stones and very radio opaque stones, but for this case, it is a large stones and faintly radio opaque. So ESWL is also not a good choice. How about PCNL? In a prone manner, this is also not a good choice because we cannot tackle the ureteric stone simultaneously. So ECIRS would be the answer. So let's move on to the patient preparation. As you remember, this patient has drug allergy to tazocin and cephalosporin. And also she has multiple resistant strain organisms grown in the conduit urine. Plus, she has stage 5 chronic kidney disease. This has limited our choice of pre-op antibiotics. So after consultation with microbiologists, we have decided to use a course of renal dose gentamicin with vancomycin given 1 week prior to the operation. For the position rise, we choose the modified lithotomy position with left loin elevators, just as an ordinary case for ECIRS. And of course, we need a two-team approach to tackle the stones. So here will be the surgical setting. As you can see, our PCNL team will stand on the left side of the patient. That's mean a stone size with an ultrasound. And our URS team would stand between the legs of the patient, and C-arm and the monitor will sight on the right of the patient. And an anesthetist and the machine will place on the cranial side of the patient. And you may argue that actually for this case, lithotomy position is actually not necessary because the retrograde access is from the conduit instead of the urethra. This is correct. However, if the URS team surgeon stand on the right side, his mobility and the movement will be limited by the C-arm. So we have deployed this kind of surgical setting for this patient. So here's would be the intraoperative technique. We did a low pole puncture with ultrasound navigation system with a color Doppler mode on to avoid hitting major artery. And after we did the puncture and insert the guide wire, we will use the semi-rigid URS inserted peri-guide wire to ensure there's no inadvertent injury and ensure this is a safe check. We have placed two guide wires, one for working and one for safety. For the safety guide wire, we retrieve it with vestibular cystoscopy to form a safety loop. And we dilate the track afterwards to French 24 with Alkan dilators. And then ferment the stones. And we would, in our cluster, we would use a shock pulse for fermentation because it has the good stone fermentation and also it has a suction device in the shock pulse. And the retrograde team, mainly their job is to flush and push the ureteric stone back to the renal pelvis to allow stone suction and fermentation with shock pulse. And for the exit strategy, we will use a Medicot insertion for drainage. So here, I apologize that we didn't have
Dr.
any.
Fai, you have 1 more minute for presentation. Thank you.
Okay, sorry. Here's the intro of fluoroscopy theme. And excuse me my time, and I will go for the peri-op findings. The operative time will be 65 minutes. And we found it's a matrix-like stone, actually, and there's no stricture over the anastomosis. Here's the post-op KUB, show a complete stone clearance. And post-op, there's no hemoglobin drop, and the patient was discharged. To our surprise, the stone analysis come back to be 90% carbonate apatite stones and also 10% albumin. We suspect it may be due to some sampling error because we has just taken the hardest parts of the renal stones for stone analysis. So subsequent follow-up show no stone recurrence. So to conclude, actually, for post-radical cystectomy patient, stone formation is quite common. And ECIRS is actually a good surgical option as it can provide both antegrade and retrograde access to the stone. And technically, it is not affected by urinary diversion. However, it may be quite labor-intensive. You require at least 2 surgeons and may need to overcome a learning curve if you are new to the ultrasound puncture technique. So last but not least, prevention is quite important. Although we, as a surgeon, we always like to challenge ourselves with complex and large stones, this is important for this kind of case as this kind of patient with post-radical cystectomy, actually stone formation is most of the time is preventable with balancing the electrolyte. So here's this end of my presentation and welcome any questions. Thank you.
Thank you, Dr. Fai, for your excellent presentation. It's quite a complex case as
Yes.
with according to our topic. So I would welcome our panelists. Probably we can start with Dr. Chandra first. If you have any comments or any questions, please, Dr. Chandra.
Good afternoon, everyone. Thank you for including me as the panelist. The case presentation is very good. It's a complex case. Definitely supine position PCNL is very important here to have an access from below, as you mentioned.
Yes.
One additional point I want to say is sometimes the ureteroileal anastomotic junction may be narrow. So one should be careful. And after removing the stones, if you have any difficulty in passing the flexible scope, you should not be in a hurry, do the balloon dilatation, and then manipulate less from below. This is the only additional point because majority of times left side uretrovesical junction narrowing is very common. One of the common complications long-term in the radical cystectomy patients. Rest all you managed very well. Excellent.
Thank you. Thank you for your comment. Yes, we also afraid of the anastomotic stricture at the beginning. So we will choose the antegrade approach to thread a guide wire in, and then we would well roll our flexible URS to assess the anastomosis. Luckily, there's no stricture, and we can pass the flexible URS up to the PUJ. So
Very good.
this,
Very good.
thank you.
Thank you.
Thank you, Dr. Chandra. Dr. Indra Warman, probably, do you have any inputs?
Okay, thank you, Dr. Diandra, and thank you as well. Very good afternoon, and our distinguished Professor Chandra here also, and congratulations to Dr. Ma for your very nice cases. And I just have two questions. The first is why you choose the lower pool access, because we know that we have a very huge burden in the UPG and the ureter. For me, if I have an obese patient in a supine position, it will be much easier for us to access from the upper pool rather than use the lower pool. And my second case is the patient have a very good management, but due to COVID delay, so the patient
yes.
up with a sad ending. I say the GFR is not increasing. What do you think about if the patient have previously nephrostomy and weights, because we see the parenchymal thickness is still quite okay in this 1 year ago. Okay, thank you.
Okay, thank you for your questions. For the first question, we choose low pole puncture because the upper pole calyx is actually saturated with the stone. We were afraid of puncture onto the stones, and for the low pole puncture, the advantage is that because the system is quite hydronephrotic, we can easily insert the scope, and we didn't shoot mid pole because there's an acute angle to tackle the upper pole stones. So low pole puncture in this case has two advantage. One, we can assess the upper pole stones with milder angulations. And second, we can deal with the ureteric stone better if we choose the local approach, and we can angulate down the nephroscope, and we can assess for our URS team, we can push the stone upwards better, and if we encounter the ureteric stone from the low pole, we can suction them better. So for the second question, yes, we note that there's a delay in the management from the time we suspect there's a stone disease to the surgical treatment. So the renal parenchyma is actually preserved. So we choose to continue the operation, and we suspect the range of EGFR is due to the underlying medical disease, because this patient actually has quite poorly controlled DN. And the renal function pre-op is already deteriorating. And with post-op, we didn't find there's persistent hydronephrosis after the operation. So we suspect this is not a post-obstructive cause, not a post-renal cause of failure. Either is mainly majorly due to her medical disease and natural progression of the chronic kidney disease likely.
Thank you. I satisfy with your answer. Please, Dr. Diandra.
Okay, thank you, Dr. Indra Warman. Probably I have a few questions as well, Dr. Ma. Also regarding actually not the stone per se, but in order for you to approach a kidney stone with ileal conduit, we have to know the anatomy first of the lower tract, especially what Dr. Chandra mentioned before, the junction or the anastomosis. Actually is very important. You said previously that you didn't find any strictures on the anastomosis. Did you know what kind of anastomosis was made for this specific patient?
Yes, this is a Wallace type 1 anastomosis.
Okay.
So actually, we would expect the track is quite straight, and because it's not a breaker, because we didn't need to have acute turn. So our hospital would do mostly Wallace type 1. If we can have enough length for the ureter, we would do a Wallace type 1.
Okay. Did you try to access it retrogradely first, or you directly assess it antegradely?
We use antegradely to assess. We use antegradely do the puncture and then insert the guide wire. And luckily, the guide wire can pass into the ileal conduit. Afterwards, we use flexible cystoscopy to withdraw the guide wire out and then exchange to a flexible URS and thread to the anastomosis to assess it. Yes.
Okay. Okay. Is that usually the technique in your hospital, or do you usually try to access it retrogradely first, and then if you can't,
yes.
you go antegrade?
Yes, in normal patient, we will assess this retrogradely first because we have to avoid to rule out any ureteric, for example, stricture or ureteric injury first before we dilate the tract and do subsequent ECRS. But for this case, we didn't because we expect this is a difficult retrograde access. So we try the antegrade approach to do. We think it would be a safer way because we don't like what we were afraid we will traumatic the ileal conduit or the anastomosis.
Okay. Okay. Thank you. Yeah, I think strictures is urethral anastomotic stricture is one of the most challenging findings if you want to do ECRS on a ileal conduit. There's a research I think in Europe to institutions from Norway and UK saying that it's probably almost impossible if you have a stricture of more than 1 centimeter. Usually it's very difficult if you want to gain access. So it's very, very important if you can evaluate the stricture first before we do any procedure going on forward. I mean,
yes.
Yeah, thank you, Dr. Ma. I have a few questions actually here from the floor. Great presentation. I'm Aulia from Department of Urology, Universitas Indonesia. Is there any metabolic intervention in order to prevent future formation of stone in this patient?
This is a very good question. For this case, to our surprise, because at the beginning we would suspect it would be some infective stones or UA stone because of the radiolucency and Hounsfield is not high. So we think it would be maybe some sampling error causing this is a calcium stone at the end. But in this kind of patient, we have to monitor the urine pH. Better to keep it around 7. And we have to correct the electrolyte the metabolic acidosis. The metabolic acidosis is rather important because if the patient has a low pH, it will favor the formation of acidic stones like UA stones, and it will, the UA stone is even harder to be monitored because it requires a CT every time. It may not be present on KUB every time. And we will also advise our patient to drink more water, to have adequate conduit volume to avoid supersaturation of the stones. So basically, it's this. And to be honest, we are as a urologist, we are not very expert in managing the patient's electrolyte abnormalities, and that's why we need to have good collaboration with renal colleagues, renal physicians, to monitor the patient's renal function and their electrolytes and urine metabolite. Yes.
Yeah. I agree with everything you just said, and probably we should remember that patients with ileal conduits have is included in the high risk stone formers. So that entitles that the patient needs further evaluation and management. So we still have to rethink about that as well. Although it's time is up, I just there's another question, but just a quick poll. Would anybody here agree to an ESWL first before the ESERS? Hands up if you agree with that. Okay, I think that answered the question. Thank you, Dr. Ma.
Thank you.
We can proceed now to the second presenter, Dr. Fat Yet Hay, with the title of the presentation is Simultaneous ECRS with Contralateral Side RIRS for Bilateral Renal Stone. Dr. Hay, you may
Hello.
proceed.
Good afternoon, everyone. Oh,
Good afternoon.
oh, yo. Can you all see my screen?
Yeah,
Okay.
perfectly.
So, good afternoon. So, my topic will be simultaneous ECRS with a contralateral side LIRS for bilateral renal stones. I'm Dr. Fayette Hay, representing Hong Kong UA. So, some background information from the patient. It's a 42-year-old male, enjoying a good past health. He was first referred to our clinic, complaining of on and off left side loin pain for 3 months. Initial workup shows that the metabolic workup was unremarkable. The patient has a normal renal function. And on the first KUB, we can see that there's multiple left side renal stones up to 2 cm, and also a 1.5 cm right side lower pole stone. An NCCT was arranged for the patient, confirming the diagnosis of a multiple left side renal stones and a 1.5 cm left lower pole stone. We can see that in both kidneys, there weren't much hydronephrosis. So a traditional PCNL would be rather difficult on the left side, and also cannot tackle the stones on the right side as well. So after discussion with the patient, we decided for simultaneous left side ECRS and the same section right side LIRS. The patient is going to be put into a supine, a modified supine position, just like what Dr. Ma has described just now. So here's the intro video. At this point, both the ureters have already been cannulated with guide wires. You can see that this is the left side UO. So we're just entering with a French 6 7.5 semi-rigid URS. I'm just gonna fast forward a bit. So here we'll reach the PUJ, and we encountered the renal stone. At this point, through continuous irrigation from the retrograde team, we actually dilate the system a little bit so that the antegrade team can have an easier puncture under an ultrasound guidance. So here, the puncture is going on. Unfortunately, I don't have the ultrasound footage with me, but you can see that at this point, we have actually fed in a metal guide wire, which we use to dilate the tract up to French 12 first. And then for our center, our practice is that we'll then insert a French 10 semi-rigid URS from the antegrade channel as well, and place in a second guide wire under direct fission. And after that, we will further dilate the tract to French 18 and start PCNL on the antegrade team. And here, after leaving the left side ureter, we'll enter the right side ureter. And then place in a second guide wire and feed in a French 10 and 12 extract sheath. For our center, we will use a flexible and navigable ureteric extract sheath, fans in short form, which utilizes a flexible distal end of the extract sheath and also allow for suction forces. So larger fragments from our LS can actually be suctioned out during the operation, which leads to a much faster and more effective surgery. So here we use French 7.5 disposable flexible URS. First, we'll do a complete rhinoscopy to locate the stone. In this case, we're now in the right side kidney, so the stone is at the lower pole, which I'll quickly skip to. We do the laser. So we'll not bore you guys too long with the LIRS video. Everyone knows how it goes. So here, so you can appreciate the effectiveness of using a fan's extra sheath while doing the RIRS. So with some rather large stone fragments after using a laser fragmentation, but then with just the French 10 axial sheath, we can actually suction out quite large fragments, which saves a lot of time when we're doing the RIRS compared to a traditional complete dusting of the stone. So here we have completely fragmented the 1.5 cm blow pole stone over the right side. We're just suctioning out the fragments. So afterwards, we'll do another complete rhinoscopy. And then we'll do, finally, we'll put in contrast to do a completion hyelogram. Then we'll withdraw the sheath together with the flexible ULS to check for any ureteric damage. In this case, it's a Trexler grade 0. So lastly, we'll insert the axial sheath over the left side. So we join back in with the anti-grade team to make sure there's also complete stone clearance over the left side. So in the video, we can see we're doing a complete rhinoscopy, checking all the calyxes. And in the lower pole, which is the original puncture site for the PCNL team, we can actually see the nephroscope operating. So the same thing was done. We do a completion RP and then withdraw the axial sheath. No PCN. So we do tubeless PCNL for every cases in our hospital. So afterwards, the puncture site is being sutured with a 3/0 nylon. So this is the post-op KUV. We can see the bilateral JJ stand is inserted and complete stone clearance is achieved. The total OT time is around 3.5 hours. The patient is discharged the next day. So ECLS allows for assistance via the retrograde approach. It also allows for a simultaneous procedure over contralateral side. And performing RILS with defense axial sheath allow for a much faster and more effective surgery. So in selective cases, performing ECLS with a simultaneously contralateral side RILS can save up GA sessions without compromising on the stone free rate. The end of my presentation. Thank you.
Thank you, Dr. Hay, for your complete presentation. Probably for the panelists, I'll start with Dr. Indra Warman. Probably, if you have any question or any inputs, please, Dr. Indra Warman.
Okay, thank you, Dr. Van Yet. Hey, it's again a very nice case and also good and fancy way to remove the stone with fragment with the suction. Dr. Chandra Mohan say it's a game changer. So it's very good. And my question is, do you use pre-stenting before or you directly go on? And what kind of PCNL you do with mini or with which size you do with PCIRS? Thank you.
Routinely, we don't do presenting most of the time for ECLS or PCNL cases. But if it's just RILS, then we will put in a stand for presenting. But all the time, it also depends on the OT availabilities. To answer your second questions, we do mini PCNL with a French 18 track. In our hospital, that's the standard size PCNL that we will use. And a little bit different from what Dr. Ma has just said. We also do not use a shock pulse for PCNL. Instead, we use a lithoclast.
Okay. Okay, and then can I go on, Dr. Diandra?
Yeah, sure, Dr. Roman, if you have any more
Yeah, you
questions.
see that the duration is 3.5 hours, if I'm not mistaken.
Yes, 3.5 hours.
So it's more than 100 minutes. Do you have any experience with maybe a septic condition with a so long duration of surgery and how you manage? Thank you.
Yes. So for endoscopic surgery for so long, because of the increase in the intrarenal pressure, there is an increased risk of sepsis. So in our experience, only highly selected cases that we will select to do such cases under long hours. For this patient, because he's relatively quite young, he's 40 years old, with a good past health, and we also ensure that the urine is sterile. So we're quite confident with doing a surgery of a long time with these patients. And also, maybe it's because of the fans actually sheath that we use. There's a very good irrigation system. So there's a continuous irrigation, but there's also continuous suction. So in our experience, actually the intrarenal pressure is not that high for these patients, and the sepsis rate is quite low.
Okay, I'm agree with you. Just be careful with maybe a female patient, but your
Yes.
patient is male, so it's very safe, candidate for this procedure. Thank you, Dr. Diandra.
Okay, thank you, Dr. Indra Warman. Dr. Chandra Mohan, do you have any inputs?
Yeah.
Probably. I know you do you do a lot of ECRS and fans as well.
Yeah.
Probably, please
Yes.
enlighten us.
Yeah. Thank you. Only fans and ECRS is very useful, but my caution, don't mind. When you wanted to do bilateral simultaneously, you should be careful. Because if in case sepsis come, you don't know which kidney is contributory, and your post-operative management becomes difficult. Any endo surgery, more than 2 hours, I feel is little more. Anything more than 2 hours, better avoid. If one surgery goes well, you can postpone for 2 weeks and then do fans. It is safe for the patient, especially young patient, where anesthesia can be given easily. Uh, Postpone after 15 days or 12 days, because all these procedures, if you do laparoscopy, lot of edema will be there around the kidney and ureter naturally. Even though lower pressure with fans, there will be lot of edema. So I used to do, Professor Oliver Traxler said to me, no over enthusiasm to do bilateral RIRS or bilateral PCNL. So except that, very well done. And I appreciate that stone clearance is nearly 100%. Patient is beneficiary. I appreciate that. But be cautious, more than 2 hours surgery and a simultaneous bilateral surgery. If the anesthesia risk is very high, if you can finish faster by doing 2 surgeons simultaneously for a low volume stone, it is acceptable. Thank you.
Thank you, Dr. Chandra. I have a question, actually, Dr. Hay as well, and this is actually a question from the Q&A. What is the actual indication of ECRS for this specific patient? And may I add to that? Would you consider a stage procedure, as Dr. Chandra before said, that probably you can try to do one side first, and then you do it on another time, probably 2 weeks after that you do the ECRS. I have a few questions actually. That's the first question. You can answer this question first. Dr. Hay? Oh, I think he's
Yes, Dr. Diandra, particularly I do, but not so many because our stone burden is, if bilateral, sometimes is quite big and it's not like Professor Chandra Mohan said, is exceeding 2 hours, and it's also, I don't have a high power laser in my center, so it's very mandatory to you to have a high power laser, holmium laser or TFL to do a simultaneous bilateral IRS. Thank you, Dr. Diandra.
Yeah, thank you, Dr. Indra Warman. Dr. Hey, hi, back. You were
Yeah,
gone for
sorry.
a
The
few seconds there. Okay.
connection's a bit unstable.
Yeah, may I ask the question again? So actually, for this patient, what is the indication for ECRS? And would you consider doing a stage procedure for either side, knowing that you're gonna take more than 90 minutes or 120 minutes doing both? Please, Dr. Hay.
Yes. So for our center's routine practice, we do supine PCNL. And in this case, because there isn't much hydronephrosis over the left side, so to facilitate puncture, we will always start with using a semi-rigid URS over the PCNL side. So I think it's a routine practice for our center to always consider ECRS, even though it's a small stone over the same side. In this case, even if we're just dealing with the left side, because the stone load is quite high, it's a partial staghorn stone with one of the stones being over 2 cm. So just doing one side, we will routinely put in a flexible URS to check for stone clearance. In this particular case, because we discussed with the patient and he's very keen for just having everything done under one session. So we try to do a bilateral procedures for him. And intraoperatively, we have very close communications with our anesthetist as well to make sure everything is going smoothly, that the vitals are stable, that there's no spike of fevers, and any sign of sepsis. But then again, we only do it in very selected cases.
Yeah. Okay. Okay. Thank you. I think that's the one thing we can take from this is that this kind of procedure is possible, although you have to have a strict case selection on who you can do this type of procedure to. So probably not all patients with bilateral kidney stones that you can do bilateral procedure simultaneously. But this procedure is able to be done. Dr. Indra Warman, do you have any other question?
What kind of laser setting you use, Dr.
What kind of laser? So we actually use a holmium YAG laser. We do it under the fragmentation mode. High power, but not very high frequency. So we don't want the fragments to be too small. So we want it to be easily suctioned out with the fans and also from the anti-grade team.
Okay. And do you think that you cannot finish the left side by PCNL alone? I can come back to the indication of why you use.
Yes. Sometimes if the stone load is it's quite high over the lower pole, some of the stones will be hiding just beneath the sheath from the PCNL, and I think it's a very good way to check with a flexible URS to make sure that there's no stone escaping.
Okay.
Okay. Thank you. Because the time is up, probably I'll just have a quick summary. Although it's possible, as we discussed before, but beside pressure, we also have to think about temperature. That's one of the things that we have to evaluate if we're doing, especially if we're doing bilateral procedure. So make sure you have a good setting. You have a good tempo of when you do lasing on and lasing off, so that it's safe for the patient. So we don't want to pass a certain threshold of temperature it's better if we can know that the pressure is below 43, 45 degrees Celsius, if it's possible. Unfortunately, up till now, we don't have any gadget, any system of how to evaluate the temperature inside. Thank you, Dr. Hay, for your presentation. For our last presentation today, for this topic, so as you know, we've already done extraordinary anatomy for complex renal stone. We have bilateral access as well. It's not going to be complete if we don't have a horseshoe kidney. So the last presentation is going to be presented by Dr. Ting Yao Cheng with the title of Management of Renal Stone in a Patient with Horseshoe Kidney, a Case Report and Clinical Implication. Dr. Cheng, the time is yours. I think you're still muted, Dr. Cheng. Yeah.
Hello, can everyone hear me?
Hi. Yes, perfectly. Go ahead.
Hey, hi, afternoon. Okay, and let's get started. And first, I introduce myself. My name is Ting Yao Chen, and I'm from Taiwan, and I work at Ma Jie Memorial Hospital, which located in Taipei. And to get started, Ms. Xiao is a 58-year-old female, and she has underlying of hypertension, which was controlled with medicines for more than 10 years, and no other systemic disease was noted by herself. So she presented to our emergency department with complaints of acute onset of left flank pain and nausea and vomiting for hours. And on arrival, her vital signs is relatively stable except for elevated blood pressures, which up to 170. And her consciousness is alert and oriented, and physical examination revealed left CV angle knocking pain. So her initial evaluations, the blood test revealed there's systemic infections, which white blood cells up to 14,000. But her renal function is relatively normal, which creatinine is 1.0. And urinary analysis revealed gross hematuria and microscopic hematuria, and severe pyuria. And the KUB taken in the emergency room revealed left renal stones, and the renal echo revealed left hydronephrosis and left renal stones. So after symptom control, she was referred to our outpatient department. For this too, the left side is her KUB, and there's a high density opacity over her left kidney. And the renal echo revealed left side hydronephrosis with some stone in the kidney. So after she was referred to our outpatients, and a non-enhanced CT was arranged for potential surgical intervention in the future. And the CT revealed an incidental finding of horseshoe kidney and a left UPJ stone, which up to 12 millimeter in diameters with hydronephrosis, and another left renal stone up to 14 millimeter in diameters, and with average household units around 900 to 1,000. And this is the image of her non-enhanced CT. And you can see the structure of her kidneys. The oriented is different from our normal patients. And this stone is located in the UPJ, not the calyx of the kidney. And this side is another renal stones. And this is another view. This one is the UPJ stone, and this one is which located in the lower calyx of our left side kidney. So the diagnosis is congenital horseshoe kidney, left UBJ stone with hydronephrosis and a left renal stones. And the last one is UTI. So considering her anomaly of horseshoe kidney, so we provided her with the treatment plan of IRS, and the patient agreed. So she was admitted for flexible ureteroscopic lithotripsy. We use Holmian laser, and suction shoes and retrieval basket was used during the surgery. And we routinely use C-arm to guide it during the surgery. WJ stent was planned to place after surgery and removed 2 weeks later. So this is the image during the surgery. This is the stone, and most of the stone was suctions with our suction sheets, and another some fragments was removed with the basket. So reviewing her outcome of the surgery, the operative time is 55 minutes, and the total length of the hospital stay is 2 days. The patient discharged the day after the surgery, and no fever or sepsis was noted. And did we achieve stone-free? There is a 3mm fragments captured by the KUB at the end of the surgery. The KUB is captured on the day after the surgery. So the stone-free might depends on the criteria, which might be 2mm or some view as 3mm. And there is no complication during the surgery or after the surgery. So the conclusion is, without flexible ureteroscopic lithotripsy with laser is a relatively effective and safe options for patients with horseshoe kidney. And this is my presentation. Thank you.
Thank you, Dr. Cheng, for your presentation. May I invite Dr. Indra Warman first, probably to give his feedback and questions. Unfortunately, I think Dr. Chandra is currently attending an event, so probably he'll join us back whenever he can. But probably we can commence with the discussion. Please, Dr. Indra Warman.
Okay, thank you, Dr. Cheng, and thank you, Dr. Diandra. My question is regarding to the surgery in this patient. You have a significant infection, pre-operatively, with increasing leukocyte on the blood and also the purulent urine, and how you manage this patient? You send to the urine culture to treat first, or you directly perform the surgery?
In our hospital, we routinely give antibiotics. We use sulfametazole since admissions. So at least 1 to 2 doses of an IV antibiotics have given before the surgery. And urine culture were routinely collected before the antibiotics given.
Yes, and we see that the picture of the stone is like a matrix stone with severely infected in urine. How you manage the patient post-operatively to avoid sepsis?
We routinely keep the IV antibiotics from the admission. So sulfametazole was keep using after surgery. If there's any culture result, and we will adjust the antibiotics. And another way is that we routinely perform blood draw after the surgery within 4 to 6 hours. So once the patient back to the ordinary world, we collect the blood. And if the CRP or white blood cell was too high, and we will routinely give fluid resuscitations and albumin, but this is not happening in these patients.
Okay, and can you give us some tips intraoperatively to avoid postoperative sepsis in your case?
Oh, we think because in this case we use suction sheets, so the irrigation pressures on the pump we kept below 300 300 of water. I forgot the unit.
Yeah.
Yeah, we keep below the 300s, and if we are not doing the suctions, we did not connect the suctions, then we keep the pressure under 200 or 100 or 150. And when we were perform basket retrieving, the visualization is not required as laser lithotripsy, and we adjust the water pressure to below 100. But it might adjust depends on the visualizations. So we will adjust the water pressures during over the surgery.
Do you use fans also, flexible and navigable suction, or you use this scope?
So probably the question is, do you use suctionable access sheets, fans, or do you use in-scope suction, direct in-scope suction, Dr. Chang?
No, through the suction sheets, through the sheets. The sheets, the tip of the sheets is flexible, so we flex the sheets to approach the stone fragments and suctions out through the sheets.
Okay, and my last question is, do you evaluate the UPG of this patient to recognize any possibility of stenosis? Because most of the horseshoe kidney have a stenotic UPG. Do you evaluate the UPG before you finish this surgery?
Unfortunately, we did not survey this aspect.
Yeah, because I have also some experience with the recurrent stone in the horseshoe kidney, especially in old population, and it's due to the anatomy of the UPG that was climbing the isthmus. And so, yeah, in this case, you have to inform the patient about the possibility of recurrent stone later on. And also, if you can perform any correction, you can correct the UPG or stenosis. Okay. Thank you, Dr. Diandra. Maybe it's your turn.
Okay. Yeah, thank you, Dr. Indra Warman. Very interesting discussion here, because I think horseshoe kidney is not a unicorn anymore. I mean, I think all of us here probably encountered one or two or probably three or more horseshoe kidneys, and usually with stones as well. So I think these kind of discussion needed to be brought up more in stone kidney patients with variable different anatomies. I have a few questions here from the Q&A box. How do you decide, Dr. Cheng, in your center between RARS and PCNL in horseshoe kidneys? Would you consider PCNL in considering if you consider the stone burden? And if I may add, you notice that you said in your presentation there's a 3 millimeter residual stone afterwards. Would you think if we approach it by PCNL, it would be stone-free? I mean, literal stone-free. And why would you think there are a residual stone at the end of the procedure? Please, Dr. Cheng.
Thank you. This is a good question. And I think considering the stone burden of these cases, PCNL might be appropriate and good choice. But I think the choice of the surgical methods might differ by the surgeon preference, because we were not that familiar with the anatomy of the horseshoe kidney. So maybe my teacher were worrying about the anatomy anomaly. So provided with a more minimally invasive method. And the other question, why there's a fragment still in the kidney, we think when I review the image captured by the TV, by the computer, there's no obvious fragments seen during the surgery. So we think there's might some angle that flexible ureteroscope could not see under a direct visualization. So, but when we check by the C-arm during the surgery, we did not see that fragment. This might be limited by the power of the C-arm in our OR room, and I think this might be some angle of the calyx, so that we could not see the fragments during surgery.
Okay. Thank you, Dr. Cheng. So, in all horseshoe kidney cases in your center, you do RRS. Is that true, or you do PCNL as well? If the stone burden is higher, I mean.
Mostly RRS, as I reviewed. Yeah.
Okay. Thank you, Dr. Indra Warman. Do you have any other question?
No, Dr. Diandra, just it's a matter of the fragment, insignificant fragment. I think 3 millimeter. I think it's not a big. We can manage it with an easier way later on. But contrary with Dr. Cheng, in my center, I have around 9 or so kidney along my day and along my career, and most of them we treat with the PCNL because it's a huge burden, and we can just please, Dr. Cheng, do not be worried, because horseshoe kidney is some phenomenon that have an advantage for PCNL. But first is about location. Kidney location will be situated lower, so it's very easy for us to puncture via the upper pole. And the direction also, orientation of the kidney, the upper pole will be situated more lateral. So if you puncture to the upper pole, you can easily also check the ureter or the lower pole as well. And the third is the vasculature of the horseshoe kidney is an upper pole is less vascular, so I don't think it's will be very difficult for PCNL. So please do not hesitate to try PCNL. You will like it, especially in a Caldeco modified supine position, of course. Thank you, Dr. Diandra.
Thank you, Dr. Indra Warman, for your sharing. I believe there's a research as well. It's in 2015 actually, evaluating whether PCNL or RARS in horseshoe kidneys. They found actually for complication, the only advantage is actually just complication. But of course, it depends on who's holding the gun. As Dr. Indra Warman probably told us previously, that if you have a center who usually does PCNL with very good results, I would encourage you to do that. But on the other hand, if you do RARS, it's okay as well. But we still have to evaluate the stone burden as well. So if it's not possible for you to evaluate it or treat it with just RARS, probably a combination is also viable, either through PCNL or ECRS. I think we have a good discussion here. Unfortunately, Dr. Chandra Mohan is not able to join us until the end, but no problem. I believe we had a fruitful meeting this afternoon. Just I want to have all the questions answered, all the stones turned. Just show of hands. Do you any of you here perform a pelvic urine culture if you suspect there's an infected stone? There's a question from Dr. Anika from Pakistan. Is there show of hands? Do you do pelvic urine culture? Yeah, I usually do, and Dr. Indra Warman as well. Usually, if the patient has suspected infected stone, we usually do that because this is not perioperatively. Usually, it benefits the patient post-operatively if you find septic symptoms. So bear in mind that's possible as well, especially whether you do PCNL or RARS. Both of them are possible to have urine pelvic urine culture. Thank you, Dr. Cheng. Thank you, Dr. Indra Warman. Also, it's not here, but Dr. Chandra, thank you as well. That concludes today's session, actually. But don't forget, we still have 3 more pre-event session. We still have 5 more topics beginning next week. So we're gonna have this on a weekly basis. On 4th of August, at the same time, we'll have 2 topics as well, starting from 1 p.m. Jakarta time, about congenital hydronephrosis and Gleason 3+3 prostate cancer. Please, if you already registered once, you don't have to register again. But please ask your friends, whoever you met. This is not just for the residents. If any urologist, both senior, junior, consultant, anybody want to join and pitch in with the discussion, it's possible as well. And we value and we appreciate that a lot. Up till now, it's already 2 hours since we start, and I see there's about 105 participants here. So I'm very thankful that this meeting is there's a lot of enthusiastic participants in this meeting. A lot of questions, good questions. Thank you for all the panelists. Thank you for the committee, and also importantly the presenter. We will meet again next week at the same time. Don't forget to put in your calendar, and see you. Have a great day. Have a great Sunday. Have a great week. See you next week. Thank you. Bye.
Thank you, Diandra. Thank you, all doctors.
Thank you.
Thank you, Dr. Diandra, Dr. Indra Warman.
Thank you, Dr.
Hi, Dr. Wayan.
Have a good
Thank
weekend.
you.